Hello everyone. Now I'll discuss question of respiratory system. So we have a 65-year-old man. That means a senior person. He has dry cough, weight loss and pain in the right arm over the last 2 months. Well, he was treated for community acquired pneumonia a year ago also. And other than he has diabetes, hypertension, and he has a 30-pack year smoking history, but quit smoking 5 years ago. Vital sign normal, physical examination is unremarkable. Chest imaging is shown below. Well, if you look into the chest imaging, you are definitely getting a mass in the right shoulder. Well, which of the following is most likely responsible for this patient's symptom? The answer to this question is superior pulmonary sulcus tumor. Well, if you can see in the imaging also, you can see a right superior pulmonary sulcus tumor, what we call as SPS, and commonly the used term is Pankos tumor or SPS tumor, but Pankos tumor is the most widely used term. Now, before I go to the discussion of all the options, let me tell you the basic concept about Pankos tumor, so-called superior sulcus tumor. It is a malignant neoplasm. Smoking is the strongest risk factor, like in our case also. He had a very long and smoking history is there. It arises in the superior sulcus, as is shown in the imaging also. It is in the upper part. And what is superior sulcus we talk about is a groove formed by the subclavian vessels. And the site of origin is in the apex of the lung. It causes destructive lesion of the thoracic inlet, definitely, because it is arising in the upper part of the lungs. So it's going to have a thoracic inlet. Whatever all remember, it's a malignant tumor. It will extend, and whichever structure is coming in the thoracic inlet is going to compress, and accordingly it is going to cause a sign and symptom. Well, so now apical location, as I talking to you in the previous slide also, it allows extension, local spread. It tend to go up. Now, when it is spreading, it involves the brachial plexus and cervical sympathetic chain, stellate ganglia. This is a very, very important point. Well, even brachial plexus, it involves the lower trunk. That means the two keywords that you got to remember in this particular slide are lower trunk of brachial plexus and stellate ganglia. If you remember these two terms, you understand the clinical feature of whole Pankos tumor. In addition, supraclavicular lymph node enlargement and weight loss, that's common in lung cancers. Okay. Well, now let me tell you. Let's learn some basic concept without which you not understand. So we can see these are the brachial plexus, and this is C8, T1. They come. And this make the lower trunk, okay, lower trunk. And finally, stellate ganglia is coming, sympathetic chain is coming. So now you can make out, it's a beautiful picture. We tell you what and which nerves are getting involved. Lower trunk of brachial plexus and the stellate ganglia. The point which I mentioned in the previous slide, just remember these two words. Well, one more thing I like to add, that it is the lower trunk. Ulnar nerve primarily arises from the lower trunk. That means we are going to get feature of ulnar nerve involvement. So three keywords to be remembered in this particular slide. Little bit more about anatomy to making better understanding of the subject. C8T1, and it make trunk, superior trunk, middle trunk or inferior trunk, also known as lower trunk. Okay, lower trunk, and that is being made by C8T1. Lower trunk is there, right? So one more picture, lovely picture. Look into this. Now we understood the brachial plexus, And we also know the location of this is the upper lobe. It is growing, so it will going to cause pressure from the below, and that's why it will going to just see this also. Lower trunk is getting involved by this Pancoast tumor. With this, we move on to pathology. It's again very essential to know most pancreas are squamous cell carcinomas. Why it is so important to talk about pathology? Treatment is based on this. We are well aware any squamous cell lung cancer, the main treatment of the squamous cell lung cancer is surgery. So in this case, now we can correlate our pathology with treatment plan, that what the main treatment is surgery. Only small, 3 to 5% are small cell are very unlikely, adenocarcinoma are sometimes found. So by and large, for all practical purposes, it is squamous cell carcinoma of the lung is there. Now, clinical features, triad, severe pain in the shoulder region. Our patient also has pain in the right arm. It radiates toward the axilla and scapula along the ulnar aspect of the muscle of the hand. Now you understand why ulnar aspect, because it is arising from the lower trunk, and axilla and scapula because it is C7, C8. 8 is inner part of the axilla is what we talk about. Look into this. So this is the ulnar aspect where it is getting involved. Beautiful picture, and if you remember this picture, you will never forget the involvement of ulnar nerve in Pancoast tumor. Now, the clinical presentation of pain in the right cervical or first and second thoracic nerve root. This is due to involvement of brachial plexus, lower trunk, C8T1. The point I mentioned to you, and I'll show you beautiful picture so that you can correlate with anatomy also. Second is atrophy of the hand and the arm muscle due to involvement of ulnar nerve. You can see typically, just see all these muscles are getting atrophied, beautifully visible. Horner syndrome, remember stellate ganglia was involved, which is a part of sympathetic chain. So that can lead to Horner syndrome, ptosis, meiosis, hemianhidosis, and ophthalmos. That means the eyes shrunken inward is an ophthalmos. The classical finding, but these are a very obvious finding seen very early. So you are getting meiosis and ptosis, then you are dealing with maybe a case of Horner syndrome. Look into this left eye. Okay, you can see this pupil size, this ptosis also even slight, this even pupil are slightly smaller as compared to the other side, and ptosis is definitely visible. Well, as I talked to you, we talked about nerve involvement. We talked about sympathetic chain. Now they can lead to subclavian vessel compression. Remember, don't forget, they are arising from the superior sulcus, which is made by the subclavian vessels. So they are also getting, look into this, the vessels are also involved. So they can cause edema of the upper extremity. Okay. This is a better picture. Subclavian artery, subclavian vein, and the tumor will arise like this. It will involve the lower trunk, it will involve the artery, it will involve the vein. So brachial plexus, subclavian vein, and artery are the three things which are going to get, and this is the reason why they are going to have edema in the upper extremities on the involved site. Okay. Well, if investigation, chest X-ray, always the first investigation, then CT scan, you can see lovely picture, Pancoast tumor. Treatment is the final surgery, as I mentioned in the very beginning. So this was all the basic concept about Pancoast tumor. With this background, now we talk about other options. Option B is incorrect bronchial carcinoid. They are rare, not common. They usually occur centrally in the lung rather than in the lung apex, and so definitely location is altogether different. So, but remember, in our case, the involvement is apex. So this is unlikely. The tumor may present with cough, recurrent hemoptysis, and carcinoid syndrome is rare. Something very interestingly, this is a very, very important point you should know. Recurrent hemoptysis is a common finding that we can understand. But why recurrent hemoptysis? But why carcinoid features are not so? We are going to discuss just now. It is extremely rare to have a bronchial carcinoid tumor to have involved the brachial plexus and cause harm. This is all because of location, because they are centrally located. So there is no question of involvement of lower tongue. But now I have a question for you. We know very well in bronchial carcinoid or any carcinoid tumor, to be more precise, serotonin level are increased, but they are not increased in carcinoid of small intestine, but it is increased in bronchial carcinoid. Very, very important question. So now question is, serotonin, so-called 5-HT, increase in bronchial carcinoid, but not in small intestine. And remember, it is usual site of disease is small intestine. Bronchial are usually a type of metastasis, usually. But why 5-HT is not increased in small intestine? Stop the video, write down the answer. This is a very important question. Metastatic small bowel tumor have prominent rosette formation is there. Okay. They usually have a type of rosette formation like this. And they secrete high level of 5-HT. In fact, 5-HT is secreted by all carcinoid. And it come from small intestine as well as it come from bronchial carcinoid also. But what happened? 5-HT, when it from the small intestine, it goes to liver and first bypass metabolism is there. It is metabolized. So that's why level does not increase although tumor is secreting 5-HT. So blood level remain normal. And that can lead to recurrent diarrhea, cutaneous flushing, and asthmatic wheezing can happen. But by and large, level doesn't rise much. Now, which cardiac lesions are common in carcinoid syndrome? Again, write down the answer. Stop the video. The answer are they can lead to tricuspid regurgitation and they can lead to pulmonary stenosis. They are universal question all over the world. Whichever exam you write, this question is there. Now one more universal question. Which skin lesion can be seen in carcinoid syndrome? Stop the video, write down the answer. They can lead to niacin deficiency, pellagra. And how we diagnose a case of bronchial carcinoid? We check the 5-HIA in urine, that is 5-hydroxy indole acid in urine, the diagnostic investigation for a case of bronchial carcinoid. Now look into this. This is centrally located. As I told you, they are not in the apex. Well, option C, cryptogenic organizing pneumonias. They also have a dry cough, systemic symptom that lasts for months together. Cross-sectional image shows ground glass appearance rather than a solid mass. Look into this. This is typically ground glass appearance. And Penco's tumor is again not possible because in Penco's tumor it is apex. This is all ground glass appearances there. Lung abscess, thick wall cavity with the air fluid level on the chest imaging. Okay. An affected person may have cough, hemoptysis, fever, purulent sputum production. But well, they are the they can occur in many other conditions also. But this is on the diagnostic. Look into this. This is a diagnostic. Thick wall. Just see, thick wall. Very thick wall and air fluid level is there. Look into this much better. You can see typical air fluid level is there. See the thickness of the wall. This is lung abscess. Now again a beautiful question for you. Stop the video, write down the answer. What is the most accurate way to diagnose lung abscess? Stop the video. Write down the answer in your copy. Well, how we diagnose the case of lung abscess? Chest X-ray is the best initial test. We can see a cavity with an air fluid level. I have shown you. CT scan is same thing. It can be better seen in CT, but the most accurate test is lung biopsy. It can establish the specific microbiological etiology. Now, definitely there is a question in your mind, what about going for sputum culture? Not the correct, because reason being, everyone's sputum has anaerobic from the mouth flora. The commonest cause of lung abscess is anaerobic. So sputum culture is not the answer. Let's look into option E. Mesothelioma is a malignant neoplasm derived from the mesothelial lining of the thoracic cavity, especially the pleura, to be more precise. It has a very poor prognosis. The reason being is a very rapidly is a highly malignant. And they present with cough, chest pain, dyspnea in patients with significant asbestos exposure. In fact, if you remember this keyword, asbestos exposure cancer is 99%, you are dealing with mesothelioma. And typically has a pleural thickening with a effusion if you see the X-ray. Okay. So now you can see this is the typical thing. You are getting thickening of pleura, okay, with effusion. Look into this, the CT, this is the classical chest X-ray, but definitely CT scan give you much better definition. Now, again, it's a question for you. Stop the video, write down the answer. Mesothelioma is an occupational disease. And I told you it is those who are exposed to asbestos that we discuss. But now my question is, which are the occupation where asbestos is involved? Stop the video, write down the answer. Well, shipbuilding, roofing or plumbing, they are the three professions where they involve. Asbestos is widely used. These are the people who are in dangerous of having mesothelioma. So they should be screened properly, periodically, to rule out any mesothelioma. Well, last minute revision point: pancreas tumor, superior sulcus of the lung, squamous cell lung carcinoma. Triad is severe pain in the shoulder region, atrophy of hand and arm muscle, Horner syndrome, and treatment is surgery. Thank you very much.